Session. I'm going to record the session, so it's being recorded right now. All righty, go ahead,
Hey,
please.
thank you so much, and welcome everyone. And want to talk today a little bit about preoperative evaluation. I've been in practice for 18 years, and when I started practicing anesthesia in the mid 90s, we did things quite a bit differently in San Francisco, and I think in the United States in general. And uh, one thing that's changed over the last 18 or so years is really how we've evaluated patients for cardiovascular disease prior to surgery, and things were very different back then. I remember many times on days of surgery, patients' cases were canceled for EKG abnormalities and for to send people for further workup. Patients were getting stress tested before low to moderate risk surgery, and then when stress test results would come back, we were sometimes confused as to what to do. Surgery was delayed, and I think we made a lot of cardiologists quite wealthy in the process. So in the late 90s, a group of cardiologists and an anesthesiologist got together and decided that something needed to be done about this, and the American Heart Association and College of Cardiology sponsored a sort of rewriting of the guidelines to allow anesthesiologists and surgeons to have a little bit more confidence about not feeling sort of obligated to chase down abnormalities, find abnormalities, pursue them, and make patients go through the royal workup. So when are preoperative tests really beneficial to the patient? I think that's one thing we have to ask ourselves. If there's a high likelihood of an abnormality, certainly. If the abnormality increases the risk of the planned surgery and needed anesthesia, and if knowing about this abnormality will change our decision making in some way. And not only that, but if there's treatment that is available for the abnormality, and the treatment actually will lower the patient's risk of then going ahead with surgery. And finally, if this delay in surgery to do all this would not actually in itself be harmful to the patient. So those are a lot of conditions. So let's go over some learning objectives on this evaluation topics. First, we should learn to recognize very clearly the finite list of acute, unstable conditions that will warrant further workup prior to surgery without any question. We should understand what specific risk factors related to the patient exist for adverse cardiovascular events. And this is something of a moving target of late. Looking at also the role and the limitations of some of the preoperative cardiac testing that we send patients to get. Looking at the role and the costs and downsides of preoperative revascularization, whether that's sending a patient for bypass surgery or to the cath lab to get stents. And finally, looking at the impact of medications and optimization we may do before surgery, including putting patients on beta blockers, statin medications, and antiplatelet drugs, and looking at those in relationship to their impact on outcome. I think first to start, we should just talk a little bit about tests. Now, no test is ideal, no matter how sensitive or specific it is. If we look at this this diagram here on the over on the left here, this is going to be the true case, whether a patient has disease present or disease is absent. So this would be sort of the gold standard truth. Up here, we'll look at test results. A test result will be positive or it'll be negative. Now we know that that ideally, when a patient has disease, the test will be positive. And ideally, when the patient isn't diseased, the test will be negative. Unfortunately, it doesn't always work that way. But what we want is to have a test that's adequately sensitive, and what that means, it's able to reliably detect disease if it's really there. So to look at that sort of as a number, that's going to encompass all the patients who have true positive disease and have a positive test. So we call those the true positives. And the denominator, we're going to divide that by not only the true positives, but also the false negatives. So these are all patients with disease. You'll catch some of them, you'll miss some of them, and the ratio of the true positives to the sum will give you the sensitivity of the test. Now, you also want your test to have specificity, that is, to be able to reliably rule out disease if it's absent, and to be able to trust that when you have a positive finding, that it really means that there's disease. That's expressed as looking at the true negatives, meaning no disease, test is negative, and dividing those by the sum of the true negatives and the false positives. So we want a test to be adequately specific as well. But unfortunately, when we send patients to get tests prior to surgery, we get them back, we have to consider whether really what we're getting what we're paying for. In other words, not every test is 100% sensitive. A test finding may be normal even in the presence of actual disease. And the other situation can also be true where a test finding may be abnormal even when the patient actually doesn't have disease. And that's become more of a problem in preoperative testing. A more useful concept than specificity or sensitivity is what we call the predictive value of a test. And that's going to depend on several factors. Definitely, it will depend to some degree on the sensitivity and specificity of the test, that is, how good is the test itself, but also we have to consider the prevalence of whatever disease is that we're interested in the population that we're testing. And I'll give you some examples here. To quantitatively to calculate this, a positive predictive value, that is, when we get a positive test result, do we trust it? It's going to be looking at all of the people with positive tests and deciding, looking at the true positives, dividing them by everyone who's had a positive test, whether there's disease or not. The converse is true of negative predictive value. You're going to look at the actual negative tests results where patients did not have disease, and you're going to divide those by the sum of the true negatives and the false negatives. So what does this all mean? That any tests that you're going to give a patient, there are going to be some people who where they're going to be falsely positive or falsely negative. Here we'll hypothetically look at two populations, one without the disease, the blue guys, and the people really with disease, the orange guys. And here the findings happen to be normally distributed, and we can talk more about what that means later. But the test, you have to at some point make a cut point and decide where a patient's normal and where a patient's abnormal. And you'll draw a line somewhere, and then on one side of the line, you're going to have a few people from the disease population that are going to test negative below this threshold. And same, you're going to have some people who are healthy who are going to just happen to test above the test cut point and be called abnormal, and they may have their surgery canceled or be sent for further workup. So let's take an example to sort of relate all of this together, because it's a little bit conceptual. Let's say you take 200 patients, and of these, let's suppose that 10 have coronary artery disease and 190 of them don't have coronary disease. So this sounds like a population of say, men in their 40s in the US. This would be about right. So let's test these patients with a test for coronary disease that's about 80% sensitive, that is, picks up disease about 8 times out of 10 if it's present, and it's 90% specific, that is, it rules out disease correctly 9 times out of 10 if the disease isn't there.
Rachel?
Yes.
I just have a request for
Yes.
a little slower.
No problem.
To go a little
Okay.
bit slower, because like I said,
You want me to go back a slide and go, yeah.
Sure. Yeah, that would be nice.
I'm going to go back a slide. So
Okay.
we're going to try to look at these concepts, and we'll go over it again.
Yeah, and speak a little slower.
Of sensitivity, specificity, and the predictive value of the test. So sensitivity, once again, is going to be the ability of a test to find disease if it's there. And the specificity is going to be able to reliably rule out disease if it isn't there. That is, you're not going to get some positive tests, frequently getting positive tests on people who really don't have a problem. So to relate all of this together, this is sort of an example. If you took 200 patients from a population where they have 5% of them will have coronary artery disease. So of this 200, that would mean 10 patients had disease and the remaining 190 didn't have coronary disease. So let's give these patients a test that we know is 80% sensitive and 90% specific. So what that will mean is that it will pick up disease in 8 of 10 of the patients who have disease, and it'll rule out disease in the rest, in 9 times out of 10 in this population that doesn't have disease. So here's to break it down. You take these 200 patients, and we know that 10 have coronary artery disease. We just know this because this is sort of a fact we know in the background. And then the remaining 190 don't have disease. We're going to take a test that has 80% sensitivity. That it means you're going to find it 8 times, you're going to correctly diagnose disease 8 times out of 10 when it's present. So how many positive test results should you have from this population? And the answer is going to be 8 divided by 10. So 8, you'll have 8 positive, true positive test results. Let's go over to this side of the 190 remaining people who don't have any coronary artery disease. And we're going to consider that there's a 90% specificity, meaning that 19 of these patients will be incorrectly diagnosed as having disease. So the predictive accuracy in this population is going to be the true positives divided by the sum of the true positives and the false positives. And that's going to give us a predictive accuracy of only 30%. Now, this is a test that sounded pretty good when we talked about it. We said, oh, it's 80% sensitive and 90% specific. But you can see that if you have a population like this, that the positive predictive value, that is the value of getting a positive test, is only 30%, likely to represent true disease. So let's go to a different population. Let's say now we're going to talk about 30-year-old women, not 40 to 50-year-old men, but 30-year-old women. And we're going to say that they have only even less coronary disease. They only have 2 to 3% of them will have coronary disease. So out of 200 of them, you'll say that in reality, 5 will have coronary disease, and the remaining 195 won't. We're going to give the same test to them, and we're going to see that 80% of the time we're going to diagnose disease in these 5 patients who truly have it, meaning we'll have 4 true positive test results. And 10% of the time we're going to incorrectly diagnose healthy people as having disease. So that here are 19 positive test results that are falsely positive. And we'll again we'll divide these guys up. We're going to take the true positives and divide them by the sum of the true and false positives. Now look at the predictive value. It's gone down. It's only 17%. By looking at a population that has less disease prevalence, a positive result from a test becomes a lot less sort of conclusive or persuasive, we say. Just to really beat this sort of death, let's consider now a population that's got a lot of coronary disease. Let's say we'll look at 60 to 70-year-old men with diabetes. We'll say that 1 in 4 of these patients has coronary disease. Probably more, but let's just, for the argument's sake, say that this is the case. Again, of the 50, we'll go through the same arithmetic and now find, wow, look what's happened. The positive predictive value has gone way up. So when one of these patients gets a positive stress test or whatever test we're speaking of, that's 73% likely to actually be accurate and predict real disease instead of just a positive test result. So very important to consider who we're testing when we're sending patients to get any test, regardless of what it is or why we're getting it. So, and then if we're looking at, I won't go through this in great detail, but if you're trying to rule out disease, the converse is true. That is, the less frequently disease is present in a population, the more likely that the negative predictive value will be valid. As you can see, as you look at a population with the higher prevalence of disease, the positive predictive accuracy actually goes down. So that means when you have your 70-year-old patient with peripheral vascular disease who has a negative non-invasive test, that it shouldn't make you feel all that much better. So why is predictive value a more useful term? Because they take into account some characteristics of not only the test, but also the patient being tested. Again, prevalence of disease in any group of patients that we're testing has value as follows. The higher the pretest probability means the higher predictive value of any abnormal finding, and the lower predictive value of a normal finding. Low positive predictive value is less of a problem. However, if we have accurate and safe ways to confirm when the tests are available. So the problem is that we don't. And if you don't understand the concepts, then we're getting patients in trouble frequently. So I referred earlier to the guidelines that have been written by the American Heart Association to try to help us sort out the morass of problems. Certainly, postoperative cardiovascular adverse events are a big problem, and so it's something that we needed to address. But rather than just sort of testing patients out of a sense of fear and dread and possible litigation, delaying surgery and creating a lot more costs and sort of agony to the patients, they decided to make some recommendations. And when they make recommendations, there are some things we need to understand about how recommendations are made. For one thing, they talk about classes of recommendation. You see across here, class 1, 2A, 2B, and class 3. Classes of recommendation essentially mean, what are you really trying to say? Are you saying it's good, or is doing this good, or is it bad? Now, a class 1 recommendation means, here's the language that they use. It's saying this should be done, it's recommended, this, whatever the intervention is useful and beneficial. That's very strong language, saying that this is something you should do. You should give patients oxygen when you give them anesthesia, for example. That would probably be a class 1 recommendation. Class 2A is that the benefit is greater than the risk, but it's not nearly as clear. You can say that doing an intervention is reasonable, it could be beneficial, it's probably indicated. A little less strong is 2B, saying it may be considered, might be reasonable, usefulness in some cases unknown. So now we're getting a little less enthusiastic. And over here on the right are class 3 recommendations, which in other words mean this is not recommended, it's not indicated, in fact it may harm the patient. So over on the right you can see that you have levels of evidence. So all this means is, on what basis are we giving these classes of recommendations? So a level of evidence that's the highest level means that the recommendation came as a result of multiple randomized clinical trials or large meta-analysis where the results of many trials are combined. So this is a very high level of evidence, and meaning that we're very sure that this is true. Level B is somewhat less sure, maybe the result of a single randomized trial or observational studies, which are becoming a lot more common. And level C, which is the lowest, is usually based on expert opinion and often case reports. Doesn't mean that those aren't important recommendations, it's just that we can't give them the same weight. So who should get an EKG before surgery? What do the 2014 practice guidelines tell us? So back in the day when I was trained, we were getting EKGs on everybody over the age of 40, even if they were getting a cataract operation. And this was leading to a lot of flurry of activity when EKGs weren't normal, and we were sending patients for invasive studies before a cataract operation. This is things have changed quite a bit these days. So there's no class 1 recommendations anymore on who should have an EKG before surgery. So they're not saying about any patients, you got to do it. This is truly crucial and necessary. So this is reasonable to do for patients who have known heart disease. They have a significant arrhythmia. They have peripheral vascular disease. They've had a stroke or a TIA, any one of those 4 issues, and they're going to undergo intermediate or high risk, otherwise complex surgery. So, and that's a level of evidence B. So that's the strongest recommendation on EKGs we have. Somewhat less enthusiastic would be patients who have no clear history of coronary disease, or we don't know, but they're going to undergo intermediate or high risk surgery. Who do they say it's class 3 don't get it? Patients who have no clear history of heart disease and they're undergoing low risk surgery. What's low risk? This is going to be mastectomies, TURPs, ambulatory surgery, outpatient surgery, knee arthroscopies, etc. So there are some limits, though, on these guidelines. There are a lot of patients that aren't addressed here. So one thing we mentioned is there are no class 1 recommendations anywhere. So the recommendations are somewhat soft. They're silent on patients undergoing low-risk surgery who have high-risk characteristics. And they're also silent on intermediate-risk patients, say patients who have diabetes or renal insufficiency, and on that basis are somewhat in the middle. So what should you be asking yourself before you decide a patient's going to get a preoperative EKG? How prevalent are abnormal EKG findings in the patient population that we're testing? And what is the relationship, if any, between an abnormal EKG and adverse perioperative outcomes, meaning death, cardiac arrest, heart attack? And are there better predictors than the appearance of the preoperative EKG? And if we do get an EKG and we find something abnormal, when are we obligated to provide further workup for this abnormal finding? And could that process of further workup actually be harmful to the patient? On the other hand, does having a baseline EKG, that is, what did your EKG look like before we sent you to surgery, clarify the significance of any kind of postoperative findings? For example, if a patient gets chest pain the day after surgery and we get an EKG and the EKG is abnormal, would it have been helpful to have an EKG performed the day prior to surgery just to compare it to see whether these constitute evolving findings or whether this is just the way an EKG has always looked? So to go back and look at how common you would find an abnormal EKG in a patient, there were a couple of studies done that looked at this, and they looked at 2 different groups, one of patients over age 50 and another over age 70. So of the over 50-year-olds, nearly half of these people had some abnormality on their EKG. That's a lot. And if you're looking at the older group, about 75% of these patients had some kind of abnormality on the EKG. They weren't pristine and perfect. In the older group, they actually found that 1 in 3 had Q waves or some kind of abnormal T waves. And more than 10% had some kind of non-specific ST segment deviation. So things that might actually concern you if you got them, but you had no knowledge of the patient or understanding of what it all meant. So then they looked at the relationship between these people's EKGs and any adverse perioperative, postoperative cardiovascular events, that is, clinical events that would be clinically important. They actually said that the abnormalities were not predictive of events in these geriatric surgical patients. What did predict postoperative adverse events were not surprisingly, higher ASA status and a previous history of congestive heart failure. So what do we need to do that? We need to do a good history and physical. And the EKG looks like it's really not all that helpful in these guys. Now, in looking at the relationship between abnormal EKGs and adverse events in the younger group, the only thing that they found were that bundle branch blocks were in themselves mildly but statistically predictive of adverse events. But if you looked at the presence of bundle branch block in conjunction with all other predictors, including ASA status, these were not additively beneficial in predicting outcomes. So yes, they were predictive, but they were sort of along for the ride. They weren't sort of driving the increase in risk. So EKG abnormalities are common in elderly patients, as we've shown. So then the question arises is, why is the positive predictive value low for abnormal findings in predicting adverse perioperative events? We just got through talking about saying if you test a population that has a lot of a disease, that an abnormal finding is more likely to be valid. So why might this be? One is that the EKG itself lacks specificity and sensitivity for disease, and I think that's a fair statement. But I think the second possibility is even more interesting, and that is that the disease burden alone may not actually be predictive of these short-term perioperative risks and outcomes. So just to go back a little bit and say, here's a very plausible thing you might find. You get an EKG on this patient, it's mildly abnormal. What are you going to do? And I think that this is sort of gets at the problem. So what do you do? Further workup of a non-specific finding. Could it be harmful? It may delay needed surgery and allow disease to progress. Disease here might mean colon cancer. It may mean bladder cancer. A patient may have, hematuria that's ongoing and may become more anemic and require transfusion. Left heart catheterization to evaluate disease is not risk-free, obviously. Patients can actually get injured in the process. People can get kidney damage from contrast injection. And actually, more importantly, a cardiologist might find something that he or she feels he needs to fix. So what's going to happen then? Surgery may be further delayed, and the cancer or disease may advance. The patient, if he is sent to the cath lab, may be put on antiplatelet medications for stenting, in fact should be, and then that in itself may also cause adverse effects, for example, bleeding, and I've seen this happen many times, patients with cancers being put on antiplatelet medications after preoperative evaluation found that there was a coronary lesion somewhere that was sort of minding its business, and a patient's put on antiplatelet medications, and suddenly a moderately symptomatic disease became very symptomatic. And there's always a worry as well that the stage of disease will progress during all of this course of action. Left heart catheterization and all this evaluation is not cheap. It's actually very expensive, and everyone these days is practicing in an era where financial resources are not limitless. So what may happen at the end of the day is that if we're testing people for reasons that are not defensible, there's going to be somebody else who's not going to get care that's actually would have been beneficial and needed. So I think we have to just sort of, as an ethical issue, think about whether, when do we got to stop this kind of process. Now, just to sort of back up a little bit, if you get an EKG that looks like this, and we see the tombstones here in the inferior leads, this is a different story. This is an emergency, but we're talking about non-specific findings. So what about, rather than EKG, are there better predictors of outcome, of adverse outcome? And the American Heart Association guidelines indicate presence of 6 predictors that perform better. 5 relate to the clinical condition of the patient, and 1 relates to the planned surgery and sort of the invasiveness of the planned surgery. So the basis for these recommendations are a few medium-sized or large-sized clinical trials. Newer studies suggest possibly better performance from biomarkers, but the guidelines have not really caught up with these newer findings. And right now they're sort of silent on the usefulness of biomarkers. We'll talk a little bit more about biomarkers tomorrow. But for now, there's very exciting new evidence that we may be able to better predict who's going to have trouble. So if we look at this algorithm that the cardiologist and anesthesiologist as a group collectively made to try to help us make better decisions, I've sort of broken it down. This was the 2014 update. We go to step 1 and we look at any patient who's scheduled for surgery who has known or suspected cardiovascular disease. The first question along the pathway is this operation really an emergency? So, for example, does the patient have a bowel obstruction? Does the patient have hemorrhage in the brain that's going to cause herniation? These are examples of things. If the answer to those questions is yes, then you proceed to the operating room. You can risk stratify, but you proceed to the operating room. You don't stop to do a lot of workup on these people. So just barring those cases, if the answer is no, there's a second question we have to ask, and that is, does this patient have what's known as an acute cardiac condition? And if the answer there is yes, then you've got to stop the train and evaluate the patient further and treat, and then reconsider the operating room. So what we need to know is, what does that mean, an acute cardiac condition? And this is a list of conditions that are, we call them game changers, meaning suddenly the rules of the game have changed. And there's a very short list, but these are conditions for which a patient should undergo further testing and management prior to going to elective surgery. This is a strong recommendation. It's class 1. And these are critical symptomatic stenosis of the aortic or mitral valve. So a patient who's got chest pain with exertion, who's got pulmonary edema from a mitral valve or increasing dyspnea, a patient with unstable or severe angina. So angina that's getting worse in the ensuing days or weeks, or just angina that's so severe that the patient can't sort of get up and walk around. Decompensated heart failure, again, something that you've got to sort of stop and address. So again, that's got to be recognized and addressed. Someone with an unstable arrhythmia or symptomatic bradycardia, so they're becoming lightheaded, they're having syncope, they have inadequate perfusion or blood pressure, etc., or they're going fast, they've got an atrial fibrillation with a rapid ventricular response. Or if they've had a heart attack within the previous 30 days, that's a time when patients are by definition at increased risk for further thrombotic and complications and for ischemic complications. So if anything you have in your patient is on that list, then you got to really stop and address them. These, unless, like I said, surgery is truly an emergency, if they're going to herniate in their brain or the bowel is obstructed, etc. How do we find though these conditions? We really get them from taking a very careful, focused history and physical examination. So it's a low-tech kind of thing. This is just, well, we won't go over this in detail, but this just talks about what some of these active cardiac conditions might be. And they just go into decompensated heart failure, significant arrhythmias, again, high-grade AV blocks, Mobitz 2, third-degree heart block, etc. The valvular heart disease, severity of aortic stenosis is going to mean either it's symptomatic or mean gradients greater than 40 millimeters of mercury, valve area is less than 1 centimeter, mitral stenosis again, progressive dyspnea on exertion, heart failure, or exertional pre-syncope. Okay, so you've let's suppose you've ruled out an active cardiac condition. Then you want to estimate the perioperative risk of MACE, and MACE means a major adverse cardiac events. It's an acronym that we'll see a lot in the literature. Estimate the perioperative risk of MACE based on a combination of clinical and surgical risk factors. So if somebody is, and we'll talk in a minute about why we would call somebody low, medium, or high risk. If somebody is low risk on this basis, then we test no further and proceed to the operating room. If the patient has medium or high risk features, the next thing we do is consider the patient's functional status. And what that means is basically, can they exercise? Now, to go over the last thing we said is a patient low, medium, or high risk? There are 5 factors that we use to determine the level of risk. Existing known ischemic heart disease, previous congestive heart failure, cerebral vascular disease, so if they've had a stroke or a TIA, diabetes, or renal insufficiency. One of those 5. Now, how do we decide if somebody's had existing ischemic heart disease? They've had a known history of a heart attack. They've had a positive stress test. You see that may or may not mean they really have it, but we're using that here in this algorithm. They have symptoms of chest pain that are clinically consistent with myocardial ischemia. That means they're occurring with exertion. They radiate to an arm, to the jaw. Patients use words like, it feels heavy. I feel like it's squeezing. And you can't reproduce this pain by having them take a deep breath or lie on their side or by palpating the chest wall. Using a patient who uses nitroglycerin routinely for chest pain, again, that's considered ischemic heart disease until proven otherwise. And actually just having pathologic Q waves on an EKG. So all of those things sort of qualify. Now, if you look at procedural risk stratification, that is, are you having a high-risk operation? High-risk operations mean basically aortic surgery, major vascular surgery. This has changed a little bit now that we're doing more lesser invasive, I should say, aortic surgery. But intrathoracic and intraperitoneal surgery, open procedures, are really somewhere in the spectrum of medium to high risk as well. Again, what's low risk? Breast surgery, endoscopy, cataracts. So who's at highest risk for adverse cardiovascular events? This was a study that we're going to talk about more tomorrow, but essentially people with one of these 6 factors. And from these factors, they've come up with a class, what they call RCRI class. RCRI means Revised Cardiac Risk Index. Somebody with 1 risk factor is a class 2. Someone with 2 is a class 3, and 3 or more, you're a class 4. If you don't have any of the above, they call you a class 1. Now, the class 2 through 4 have been a population that's been the subject of some recent very large trials, the POISE 1 and 2 trials. We'll talk more about those as well. But those were trials that were randomized trials where only patients in these categories were invited to participate. So what is the rate of cardiac death, heart attack, or cardiac arrest within 30 days of surgery? Really, how big a problem is this? And if you look at the 6 risk factors and you classify people according to their status, if you look at people who have none, it's very low. But if you look at people who have 3 or more, you're getting up into the area that's possibly as high as 7 to 8%. Certainly, this is the point estimate and the confidence interval. But we're getting somewhere up in a range that's pretty scary, actually. So if you consider the patient's ability to exercise, going back to this algorithm, if somebody can do a moderate amount of exercise, then we can say, okay, good. can you do a lot of exercise? This is, and we'll talk about what this means, but can you do 10 metabolic equivalents? And you say yes. You can say no further testing is needed. Go to the operating room. If you can say, yeah, I can do some exercise, I can climb the stairs. You know, I'm not an athlete, but I can get around. I can climb the hill to get home. Again, recommendation is no further testing. Go to the operating room. Slightly less enthusiastic, but that's still the recommendation. If somebody can't do this, so they say, well, you know, every time I get halfway up the stairs, I catch my breath. You know, or they say, well, I have such bad knee arthritis, I don't know, I never try, it hurts too much. Then you're in a different category. You're over here, and you have to ask yourself, gee, should I test this patient, and would the results of the test impact decision making or the care? Now, what does that mean? If somebody's getting elective hip replacement, would it be acceptable to delay a hip replacement if it's possible that the operation is going to really is going to harm the patient? I think the answer that we would give to that is yes. If somebody has a rapidly growing tumor, that the answer may be, well, maybe even though the guy can't climb the stairs because he may have knee arthritis, let's still give him the benefit of the doubt, take him to the operating room because he's got a tumor in his stomach, a tumor in his colon. We don't want it to go any further. He really needs to have the surgery. Delaying it might hurt him. So this is now a clinical decision that you, the patient, and the surgeon and the family all have to kind of make a decision about. So getting back to this functional status question, what are these metabolic equivalents we talk about? And we decided that if you can do 4 metabolic equivalents, you're considered sort of acceptable. And what that translates to is doing some kind of vertical exercise, meaning you can climb stairs or climb a hill. What we usually ask patients is, can you climb 2 flights of stairs without stopping to rest? So that if a patient says yes, that means he or she can do at least 4 METs of work, and that's actually fairly acquitting. It's fairly reassuring. Now, when you get into higher amount of exercise, 10 METs means you actually can play singles tennis, basketball, you go skiing, and you do these very rigorous sports. So again, we say that people who have excellent exercise capacity were greater than 10 METs, good. 7 to 10, moderately good, is 4 to 7, and then if you're less than 4, that's actually very unreassuring. So will testing impact the decision to go ahead and go to the operating room like we asked? If the answer is yes, so if somebody's getting something that's really elective, like and postponable, like a knee replacement or a hip replacement, we would say that patient should go and get some kind of further evaluation. Now, here's where this gets dicey. If that's abnormal, they talk about coronary revascularization. I think certainly that if it's abnormal and you've come all this way knowing that the patient is higher risk, then sending the patient to the cath lab is actually recommended by the guidelines. That's actually very, very strong language. If your pharmacologic stress test is normal, then they recommend proceeding to surgery, considering doing things a little bit differently. However, maybe you should use some invasive monitors. Consider the possibility of some less stressful alternatives to the planned operation. So when we talk about these non-invasive testing, what are we talking about when we're sending patients to get cardiovascular workup? The most common one we do at UCSF is myocardial perfusion imaging, and this is probably most common in the US and probably most common in this country as well. This is where a radioisotope is injected into the vein, and then the heart is examined, is imaged, and they look at the homogeneousness, that is the evenness of blood flow is assessed, and it's assessed during 2 various conditions. One is when the patient is resting, and then one is when the patient's getting some kind of stress. And those two images are compared. Now, if the perfusion of the heart shows homogeneous, that is even kind of nice even distribution during both phases, both the stress and rest phases, that's considered a normal study. Now, if you have patchy, sort of non-homogeneous flow that looks the same during both phases, both rest and stress, that's usually indicative of some kind of an old heart attack or a scar. However, now if you have patchy, inhomogeneous flow during stress, but it starts looking normal again when the patient's resting, that's what we call a reversible defect, and it's consistent with ischemia or an ischemic process, and that's where we worry. We call that a reversible change. So how do we actually stress the patient, and what happens? One thing to know is that normal coronary vessels can dilate and deliver an increased amount of flow up to 4 times more than their usual when normal patients rest or stressed, or when they exercise, or when the demand for oxygen delivery is increased in the heart. Now, if you have a diseased vessel, let's say you have a left anterior descending artery that's 99% occluded, that vessel and its branches are not able to do that. So while your right, let's say your RCA and your circumflex are going to 4 times their baseline and delivering all kinds of increased blood flow, if the patient's exercising, this region of the left anterior descending, if it's diseased, won't be able to do this, and you'll actually see blood flow steal phenomenon occurring. So the diseased area gets actually less blood than it did when it was actually resting. So that's when you see the redistribution of flow. So when you have a coronary stenotic picture, usually, although not always, a patchy picture results. And here's what it looks like if you look at imaging. Over here on the left, this would be a rest image where you see blood flow to the left ventricle, and here we're looking at the left ventricle in short axis cross section, where we see the 4 walls, the septum, the inferior wall, the anterior and lateral walls. Roughly, you can see that that the tracer is going to all parts of the heart. It looks like a donut. It looks nice and even. Now over here, oops, what's happened? This patient is getting stressed, and look at the anterior wall. Uh-oh, there's looks like there's almost no blood flow there. So that would be an example where you may have, for example, a left anterior descending artery lesion, and that's during that stress that just these areas essentially just robbed all the blood supply from this area because it could, and we get this picture. Okay, so sometimes we don't use this perfusion. We actually use echocardiography instead of the nuclear perfusion imaging, and in those cases we look at the segmental wall motion and the overall function. But again, we assess them with rest and with stress. The advantage here is that you can look at the baseline left ventricular function. You can look for valvular disease, and may recognize some new information there, which you wouldn't get on the perfusion study. Also nice is that no radiation is delivered to the patient. And one kind of problem is that this is not a test that's as available everywhere, because you need somebody reading the test who's got expertise in recognizing normal versus abnormal, and your institution has to have sort of echo standards where on any given day you'll get the same kind of reading. So it's often easier for us to get myocardial perfusion imaging as well, just because it's you don't always have to have a cardiologist immediately available. So how do we stress the patient? So there are a number of ways to do it. One is, if the patient can do it, you put them on a treadmill or a bicycle and have them exercise. Now, if a patient is not able to do this, you can use a drug like dobutamine, which by its beta-1 and beta-2 agonism will increase both the heart rate and the contractility, and in doing so will increase demand and will increase blood flow to non-diseased areas of the heart. If you can't use dobutamine for some reason, let's say you have a patient who's in atrial fibrillation and you're worried about using dobutamine, you can use just a simple vasodilator, and particularly a coronary vasodilator such as adenosine, dipyridamole, regadenoson, and those will essentially do the same thing. They'll dilate the non-diseased vessels. the diseased vessels will have blood flow stolen from them, and we'll again see this patchy picture, or we'll see signs of wall motion abnormality or ischemia. So what findings do we consider highly suspicious on any of these stress tests? One would be a large area of reversible flow defect. That picture I showed you a few slides ago, that would be fairly suspicious. Or if you have multiple areas in the heart that have these reversible defects, that's also concerning. It concerns that you may have multiple vessels involved. If you see ischemia at a low heart rate, that is, the patient goes from a heart rate of 55 to 75, and suddenly you start seeing wall motion abnormalities, that's actually worrisome. Or if the wall motion abnormalities are extensive, or if during stress, rather than having the ventricular walls sort of augment their squeeze, instead it actually dilates, that's a very ominous finding. So we call that dilatation with stress. So those are findings that would really make you worry. Okay, so we're not bad at deciding who may have coronary disease if we decide to go ahead and test them. But the one question to ask ourselves is, are heart attacks that occur out in the community in non-surgical patients really the same? Do they occur by the same process as patients who get them after surgery? And I think the answer is we don't know. And I think that they're not always sort of driven by the same mechanism. So perioperative acute coronary syndrome is really driven by the neurohumoral response to the surgery. And what's happening? Catecholamines are released, and these raise the myocardial oxygen demand. And in this process also there's mobilization of metabolic substrates as a result of undergoing surgery, and these lead to a process of retaining fluid in the body, sometimes hyperglycemia. The inflammatory mediators are activated, and these can lead to vasospasm. The platelets get activated, and then any existing plaques may rupture and as a result of all this inflammatory and sympathetic activation. And this is all done because of this wounding and healing process to the body. And it looks really like plaque rupture risk with clinical flow limitation may not really be related to the size of a given plaque. So the percent that a vessel is occluded may not really be as important as the fact that there may be an unstable plaque. It may be small, but all it has to do with rupture, and it can block up the whole process. So the number of plaques you have or the size of them may really not be very important in terms of your risk of a heart attack during this surgical process. Now, during your lifetime, that's probably a different story. So what have studies shown us about the role of preoperative coronary bypass or stenting? There was one really important study called the CARPS trial, and that was done in patients who had one or two vessels that were diseased, normal left ventricular function, and they were actually randomly assigned, believe it or not, to getting revascularization or to medical management. And we'll talk a little bit about what that means. But when they looked at those people, they had no difference in the rate of death or heart attack at 30 days. And there was really no significant long-term mortality benefit to doing either coronary bypass or stenting. Now, there was a second study done by Poldermans in Holland that was even a little bit hard to believe, and that was that no mortality benefit was shown in patients who had 3-vessel disease in revascularization prior to surgery. Unfortunately, that investigator and his center now were sort of investigated for possible misconduct, and the results of those trials have sort of been invalidated. I think at least it's fair to say that we're questioning them and trying to be a little bit more skeptical, but unfortunately that's happened, and now we're a little bit back, and that may be why the guidelines now are a little bit more enthusiastic about testing people and possibly revascularizing them. So looking at the big picture, revascularization should only be considered if this would have been appropriate to do if the patient wasn't going to have surgery. So just to put it in another way, revascularization to improve perioperative outcome, if it involves only 1 or 2 vessels, We say that it may delay needed surgery because of time taken for testing. If the patient is getting a coronary bypass surgery, or the requisite period of antiplatelet therapy after stenting, and we'll talk more about that later. We know that that any kind of revascularization, if it's indicated, may improve the quality of life and symptoms of the patient, but there's really no short-term survival benefit shown. So therefore, it's not recommended that we revascularize patients just to sort of get them ready for surgery. Now, if a patient has indications for bypass that they would have regardless of whether they were going to have surgery, and that means they have left main stenosis or they have severe three-vessel disease, then there's a class 1 recommendation to go ahead and revascularize them regardless of surgical plans. So that's kind of how we sort it out. Like, we don't want to do anything special just because the patient's going to have surgery, but if they qualify to have this, on any given day, then surgery should be postponed for it. So we were talking a couple of slides ago about those patients who were randomly assigned to getting revascularization or medical management. So the question is, what does medical management mean? For medical management to prevent events in patients who are not undergoing surgery but have coronary disease include being on a beta blocker, being on aspirin, being on a statin and an ACE inhibitor.
Hello?
Yeah, hey.
Dr. Eshima, if we have a little bit to go, can they take a couple-minute break? Or
Absolutely. You want to take I think we're actually almost at the end.
okay, good. So okay.
Yeah. So so in surgical patients, it's a little bit different. So beta blocker initiation and management in surgical patients can be a little bit tricky. So as opposed to non-surgical patients where beta blockers can do no harm in a way, they're very good. We know that surgically this is a little bit different. And surgically also, continuing aspirin is controversial, and this may actually be bad. Also, probably more important than any of these things in a surgical patient is adequate pain management and good heart rate control are both sort of critical. And then insurance of adequate perfusion and avoidance of fluid overload. So these are just very kind of common sense things that in surgical patients are really important. Actually, let's take a break because I realize we have probably about a good 12 or 13 more slides, and then we can come back.
Okay, 5 minutes.
Yeah, take a stretch.
Okay.
Yeah, that was about an hour.
Yeah, no, that's perfect. I'm just writing them at 8:50. Let's say 7 minutes.
Perfect.
All right. My gosh, this is a great lecture, Rachel. I would just speak a little bit slower.
Okay, so even slower.
You and I should get on Skype after this.
Okay, definitely.
Lecture. Yeah, we'll get on Skype a little bit and yak a little bit about the.
Yeah, that'd be good.
Rachel, I was a co-author. You remember Rao Jacobs and Elettra from the early 80s, where they had reinfarction.
Oh, wow. Yeah.
Rao Jacobs and Elettra.
Yeah.
And they did two studies where their first reinfarction data were right along with Tarhan, and these are old studies from the 70s. 30% in the first 3 months or whatever it was, and
6 months
then
with
yeah, and then Rao, Jacobs, and Electra came back and they said, "Oh no, in the first 6 months it's 2%." And in their discussion, it was in anesthesiology, and they said that's because we use swans. Well, I trained there. I trained at Loyola, and the indication for putting a swan in a patient usually was the presence of a jugular vein. And well, anyway, well, of course, what they kind of swept under the rug a little bit, what they didn't discuss too much, was the fact that also increasing numbers of people were getting beta blockers. And so in 87 or 88, we did a third study, and we were using fewer swans, and yet the reinfarction rates were the same. It was about 2%, not 30%. So I think it's the beta blockade.
yeah, yeah,
What
yeah, you're right.
poise? I don't know about poise, man.
Boy,
It
I think you could do anything badly. I think, we'll talk about this, but I think the poise proves the fact that even the best tools can be put in the wrong hands.
yeah,
And yeah,
yeah,
I don't know. I mean,
yeah. That over beta blocking, I think, is can be bad because it can, and if they get sepsis, they can't crank up their cardiac output, and
crank it up. Yeah.
yeah.
Yeah, I feel worried for the same reason about these people who are sort of rate dependent with pacemakers who have their lower rate limit in the
Hmm.
50. They're going to have a colectomy or something. I
Hmm.
really worry about those people who are, going to be going 50, 55, post-op day 1 and 2 with fevers and, you
Yeah.
know,
No.
I don't know. It's
I wish we could mess with these things with a tool at our hands, in our hands,
mhm,
to increase to increase the cardiac output of these
yeah,
patients, because I think they need to an increased cardiac output, and we don't have such a device.
yeah, that's
Uh,
true.
It's
True.
it's a little bit of a yes, when they are at home playing with the grandchildren is one story.
Yeah,
When they're having have their colon taken out, it,
yeah. Well, we're
it's
getting them up and walking them. That
yeah,
actually does boost it up. If they can tolerate sitting, the upright position, maybe that's,
yeah,
we're getting really aggressive about that.
yeah,
We're,
yeah.
you know,
Yeah, I
it's,
know. That's a very important point, by the way, to stress in Palestine, because
oh,
patients don't want to move, and a lot of these patients may be fairly young, 55 or 60 years old, and they act like they're 100 years old, and oh my God, I'm a grandma, I can't move. Grandmas are not supposed to move, kind of thing, and it gets a little bit
yeah,
frustrating.
it's really frustrating.
Yeah.
We did this, we have this ARAS pathway now, and
Mhm.
we have these drawings of little cartoon people with their IV poles where, doing laps around the hall.
Yeah, yeah.
And this is what you're going to be doing like within 8 hours of coming out of the operating room.
Hmm.
It's like the rule.
Yeah.
And they're like the patients sometimes complain about it. They go, "Why do I have to walk at 1 in the morning?" It's
Yeah.
like just because you do, you know.
Yeah. Yeah.
But
Right. Just a little again. Just I'll throw in simple things like mismanaged, or words like mismanaged, laps around the hallways. Uh,
okay, oh
the hallways are
right, right,
corridors. The hallways are corridors, and laps, people wouldn't understand the word laps. And so
exactly.
anyway, but we'll talk about it in a little bit after the
Perfect.
lecture.
Okay, good, good, good.
All right, boys, it's almost
Okay.
time. It's
Ah,
almost time. No, I'll start at 12:50. I mean at 8:50. This is ridiculous.
49, yeah,
Mhm.
that's right.
Okay.
All right. So, we were mentioning that um, beta blocking surgical patients can
Give us
be
one more minute.
tricky.
One more minute.
And
One minute.
we had,
Oh, okay, you can start now.
ready, oh yeah, ready, okay. We had talked about how keeping patients or starting patients on beta blockers around the time of surgery is not without its complicating issues. The really the first and only very large trial, outcome trial looking at beta blockers was the POISE-1 trial, and it looked at the safety and effectiveness of having patients put on perioperative beta blockers. They studied over 8,000 patients, and all these patients were at least an RCRI class 2. That means they had at least one major risk factor and one minor predictor. That's not really important though. And they were going to undergo at least moderate or even complex surgery. So these patients were assigned, these people were beta blocker naive. So meaning that they hadn't been on beta blockers previously, and they were put on a very high dose of metoprolol XL. So they were put on 200 milligrams on the day of surgery, and the trial showed that beta blockers conferred a 0 to 30-day postoperative effect as follows. The beta blockers prevented non-fatal MIs, so they were able to do that. But unfortunately, they also doubled the risk of a stroke. They increased the all-cause mortality in patients within 30 days of surgery. So these are bad. And during this postoperative period, the beta blocker patient had a greater incidence of hypotension, and they had, not surprisingly, about triple the rate of bradycardia. So yes, they prevented heart attacks, but they did so at a greater cost. A stroke is probably more devastated than having a heart attack, and it killed more patients. So that tells us that, in 2014, we want to now proceed with caution using beta blockers. And here are the recommendations: with that patients who are already on beta blockers at home should continue them. So continuation of perioperative beta blockers in patients already taking them at home for a proper indication is recommended. That's a class 1 recommendation. Another recommendation is active postoperative titration of beta blocker therapy is reasonable, guided by individual clinical circumstances. And what that means is that if after surgery the heart rate is low, the patient is dizzy, and the blood pressure is low, that it may be reasonable to actually hold the beta blocker or decrease the dose, sort of guided by how the patient's doing, rather than adhering to sort of slavishly to a protocol. Also, in the following, beta blocker initiation may be reasonable in any of the following circumstances. If an intermediate or large area of ischemia or reversible flow was demonstrated on a test prior to surgery, if the patient has 3 or more of these RCRI risk factors, and if you're going to start them many days in advance of surgery so that you can assess whether the patient can tolerate them well, whether they go too slow, whether they start having low blood pressure, whether they don't feel good. So you can then, if that's true, you can down the dose or even decide it's not a good idea. If the patient has clinical indications for beta blocker use, the usefulness is uncertain. So really they're saying there are a few circumstances in which you might consider starting them, but if you do it many days in advance, don't start it on the day of surgery. So they say that's a class 3 recommendation. Beta blockers should not be started on the day of surgery. So what about aspirin in patients? Does aspirin help? We know that aspirin is very beneficial to patients who are not undergoing surgery but have had coronary disease and heart attacks. But in the surgical population, there's really been no benefit shown. And the largest trial to date of this, and actually really the only trial looking at this as a primary outcome, was this POISE-2 trial. So it was a follow-up. It was a whole separate set of patients. In this case, more than 10,000 patients who were randomly assigned to either getting aspirin or placebo. And this was a similar population, though, in characteristic to the POISE-1 trial. They used kind of a medium-sized dose of aspirin. They started people on 200 milligrams a day, and then 100 milligrams a day thereafter for 30 days. Now, I don't know what aspirin doses are like here, but in the U.S., most people are on a like a 70 milligram, not 100 milligrams, or 81 milligrams, not 100. So this is a little bit more than a baby aspirin. And patients who were in this trial, some of them, not surprisingly, had been on aspirin at home, and they had their aspirin held at least 72 hours prior to surgery. Patients who have had stents put in within we call it PCI, but who have coronary stents put in within the previous trial period of 12 months were excluded from the trial. Also important is that nobody who was undergoing carotid surgery was allowed, because there are indications in both of those populations that aspirin actually is very important. So they found that in this POISE trial, though, in all these other patients, that the rate of death and heart attack within 30 days was really no different. It was actually pretty high, 7%, but the risk was similar in both groups. Here, there's a confidence interval that includes the number 1. Whenever you see that, know right away that did not achieve statistical significance. And not surprisingly, major bleeding was more common in the people who got aspirin. Now, it was a small effect, but it was there. So recommendations for patients without previous stents are to continuation of aspirin prior to elective surgery may be reasonable if the coronary event risk is greater than the bleeding risk. That's that doesn't tell me a whole lot. But what they do say is aspirin initiation or continuation is not beneficial in patients who are not at increased risk of coronary thrombotic event and do not undergo vascular surgery. So basically, in a nutshell, there's no real benefit to aspirin unless you're one of these people who are going to have carotid disease, carotid surgery, or if you've got stents or there's some other issue that's unique. By and large, just for high-risk patients, being on the aspirin seems to make them bleed a little more and doesn't seem to protect them. So what about patients with stents who have had drug stents with either bare metal stents or drug-eluting stents with cure? I've called it DES. When that is one real concern is stent thrombosis, and there's an increased rate of late and very late stent thrombosis compared to patients who have bare metal stents if dual antiplatelet therapy is interrupted. So patients who get these drug-eluting stents should be on 2 antiplatelet medications for 12 months, unless barring some very unusual circumstances. And this is probably more important if the stents have been put in an off-label manner. Now, what does that mean? That means maybe more than one stent is put in the same vessel. That's actually considered an off-label use. And the mechanism for this problem seems to be delayed healing of the intima after the stent is put in. And this has been shown in autopsy findings. Now, what does this mean? Here are some pictures of 2 kinds of stents. On the top, here's the old-fashioned bare metal stent. And this is the roof taken off of a vessel, showing that here you can see the struts of the stent going through. And here's the endothelium here. This is re-endothelialized, but you see that there's hyperplasia of the vessel itself, causing stent stenosis. So the stent is becoming kind of squeezed down. This is called stent stenosis. Down here, so you're seeing neointimal hyperplasia. It's basically a sort of a scarring process that's going on, and that became a clinical problem for patients back in the late 90s and early 2000s. So they decided, let's find something that will prevent this intimal hyperplasia. So they put a drug in the inside of the stent that would sort of retard the healing process. So that, and in fact, they work. I mean, you don't get intimal hyperplasia, but the problem is while there is a lower rate of restenosis, the drug and the polymer prevent the endothelialization. That is that single layer of cells from from forming on the stent. So that creates sites that are vulnerable to thrombosis. So you have these kind of denuded areas on the vessel in these drug-eluting stents, and this is just an absolute magnet for clot to form. So when do we see this? I think you certainly see it usually within the first 30 days after, even with the drug-eluting stents. You see acute stent thrombosis. They define that as within 24 hours. 30% of the time, when you do see thrombosis, it's very early. But you see the majority of it within 30 days. But there's still a substantial amount, probably about 30%, that occurs between 30 days and a year, and even beyond. So the idea is, this is still a vulnerable period of time. So once a patient gets these stents put in, he or she is really kind of committed to getting antiplatelet therapy for that period of time. So if you have to go through surgery, it's kind of a problem. And I'll kind of breeze through these quickly. Don't focus on too much of the details, but this is essentially showing that that patients who got stents had their antiplatelet therapy interrupted, that they had a higher rate of MACE than patients who didn't have their antiplatelet therapy interrupted. And actually, what we found was that it was a very strong effect. The early discontinuation of the antiplatelet drug and the adverse outcome. And that really, if you stop the drugs very early, regardless of what kind of stent you have, whether it's a drug-eluting or a bare metal stent, you're still in trouble. So even if you put a bare metal stent in a patient, you really got to keep that patient on antiplatelet drugs for 6 weeks. So why is early surgery bad? I think partly it's obviously you're stopping the antiplatelet drugs, but it's also what's happening during surgery. You're getting these pro-thrombotic, pro-inflammatory effects, meaning all this inflammation creates a process in the body. And this is caused by the process of surgery itself, the wounding of from incision, etc. All of these mediators in the body are released. Platelets get sticky. There are procoagulation factors, released. You have a diminished ability to do fibrinolysis. There's increased shear stress on plaques that are already in the vessels, and the vessels become more reactive. That is, they tend to spasm more readily. At the same time, if you see all these things in the context of incomplete endothelialization of the stent, that is an incompletely healed vessel with a stent in it, and you interrupt antiplatelet therapy, you can see that you put this all together, and this is a setup for stent thrombosis with subsequent heart attack and death, actually, because these are not minor matters. If you look at people, this is a big meta-analysis of the hazards of discontinuing aspirin in patients after stenting, and the patients that are at greater risk of this MACE with discontinuation of aspirin, but the risk is magnified in patients with recent drug-eluting stent placement, and their odds ratio is huge. It's 88. So that's a really big odds ratio. So again, I don't want to go through too much of this but this was a stent registry. Stent thrombosis occurred in 29% of patients where the antiplatelet therapy was stopped prematurely. That's a very high rate. And the hazard ratio, again, 161 for subacute thrombosis. That's a very, very, that's very compelling. So for late stent thrombosis, again, still, even out of a month, it's still very, very risky with a drug-eluting stent. So just to go over this, if you look at all of the risks for stent thrombosis, discontinuation here of antiplatelet therapy, that's APT, about the hazard ratio is 152, very, very high. Again, not to beat this too much up, but between 1 and 12 months, which we call late stent thrombosis, the hazard ratio is 57 of discontinuation of aspirin and Plavix, and between the whole cumulative period, it's almost 90. So it's a very, very bad problem. Now, what happens? Suppose you do have stent thrombosis. What's at risk? Actually, they found that the death and MI rate was 64% after stent thrombosis in a pooled data. So these people aren't just having a troponin bump. These people are having a big problem and with a high mortality. So the stakes are high. mortality was between 20 and 45% from documented or presumed stent thrombosis. So again, I think we have to think about these things very carefully. This is a special population of patients. The bottom line is, don't send somebody to the cath lab, for a problem unless you're willing to live with the fact that then they're going to be committed to these antiplatelet drugs for a period of time. So, for example, in your patient who does have cancer or an unstable problem or needing craniotomy, think about this very carefully. So, just a side algorithm about the stents placed within 6 weeks. Is surgery elective, that is postponable? If the answer is yes, you delay surgery for at least 30 days with a bare metal stent and at least a year after a drug-eluting stent. This is a class 1 recommendation. So this is really important that you not deviate here. Now, if surgery is really not elective, meaning you've really got to do it, the guy can't wait a year to have new cancer operated on, then if you can, you continue this dual antiplatelet therapy unless there's a terrible bleeding risk, and then you try to still keep the patient on the aspirin. So if the person has had a drug-eluting stent placed within the year, again, if surgical delay risk is greater than the risk of the thrombosis, that is, again, for a cancer, you proceed to surgery, you try to wait at least half a year, and then when you do it, you continue on aspirin. If you can't wait, then you proceed to surgery, or if the surgery is elective, then you wait for a year and you continue on both antiplatelet drugs if possible, and if not possible, then at least you stay on the aspirin. So these recommendations are very strong. Now, does surgery require the discontinuation of the second antiplatelet drug? This may be clopidogrel or ticlopidine, prasugrel, one of those P2Y12 inhibitors. If the answer is it has to, let's say you're doing a partial nephrectomy or something where there's really a high liability of bleeding, you proceed to surgery, but you continue the aspirin. Then you restart the second drug as soon as you can once you have surgical hemostasis. So a couple days after surgery, you restart as soon as it's feasible. If you don't have to stop it, don't proceed with surgery. Keep the patient on both drugs. So what about other interventions to help lower the risk? There's really not a whole lot we have available, but one thing that looks very promising is statins. Now, statins are helpful certainly in the non-surgical population, but there's some new evidence that they may help surgical patients as well. And the reason for this is that they seem to stabilize plaques. So not only do they sort of decrease your cholesterol, but they actually have an anti-inflammatory and a plaque stabilizing mechanism that seems to decrease the vascular inflammation that may arise perioperatively. So there was one meta-analysis, meaning they looked backwards at a lot of data from multiple trials that showed a 59% mortality reduction after vascular surgery in patients who were on a statin compared to those who weren't. So that's a very big effect. And then there was one small trial that showed a significant decrease in the composite endpoint, meaning a combined endpoint of several problems: death, heart attack, unstable angina, and strokes in patients who were randomly assigned to getting atorvastatin versus placebo prior to the vascular surgery. So it's both of those trials seem to indicate that statins may actually hold some promise, and there's really very little downside to giving them to the surgical patients. So the recommendations from the Heart Association: statins should be continued if patients are already on them, class 1. Initiation of statin drugs is actually reasonable in patients who are undergoing vascular surgery, even if they've never been on it before. And starting a statin may be considered if there are clinical indications before moderate or high-risk surgery. So if your patient has a risk factor for a MACE and is undergoing even abdominal surgery, it may be reasonable to go ahead and start that person on a statin. So with that, I'm going to stop, and I know that's a lot of material, and we went through it kind of fast to see if people have questions or comments.